Well, it's a pleasure to be invited to speak here. Thank you very much. And wow, where'd you dig up that picture, Kathy? It looks like I was like 13 years old in that. So fantastic. I'm going to talk about some knowledge gaps in what we do. We've heard some real cutting edge, really cool stuff today. This is a little bit different. This is a little bit more basic. I'm going to talk about basic knowledge gaps in what we have. And I think if we're being honest with each other, I think we're going to agree that we don't really know how much flow and how much pressure we should be giving our patients to optimize their perfusion. And I can't think of a more fundamental question for a group of perfusionists. And I want to start with a very difficult case for that question. I'm not going to talk about selective perfusion. That's way too complicated. We're just going to talk about the basic. How much flow and how much pressure do I give this particular patient? And have I really optimized it? And I'm going to focus on pediatrics, but I'm going to give you some adult data to back up what I'm saying, so it's not just limited to the pediatric domain. I'm going to talk about a lot of animal work and clinical work that Kathy and I did together. And Kathy and I have been partners in this since 2002. Does that sound about right? And everything that I'm going to talk about, Kathy is my equal partner in the development of this technology. And she has been such a fantastic collaborator from the beginning, and really, honestly, one of my best lifelong friends. So Kathy, I owe you so much, and I'm so grateful to you. And I think you're going to be impressed by some of what we've dug up together with this collaboration. Let's start with this question. Does anybody know, by the way, when the first patient in Houston survived the Norwood operation? The Norwood operation started in the 1980s. And some of the best surgeons in the world were in Houston, right? So it wasn't until about 1995 that the first Norwood survived. Chuck Frazier did that. And about that time, I looked like the picture. And I was in California in a PICU around that same time. And I remember a patient being admitted to the PICU with after an Norwood. And the attending handed me a quarter and said, flip it, because that's the chances for this patient to be alive in the morning when you sign out to me. And that was the state of congenital heart surgery in the mid-1990s. And some of us were there and we remember it. I see some people older than me, so I can't be the only one that remembers that. But let's start with this case. Let's say you have a 5-day-old infant who's just had a Norwood operation for a hypoplastic left heart syndrome. They have a Blalock-Taussig shunt. They come to the ICU. Their blood pressure is 58/24 with a mean of 32. Mean blood pressure of 32. That's not uncommon for the post-op period for this surgery. Heart rate's 145. Oxygen saturations are 85, which, if you're not familiar with hypoplastic left heart, that is perfect. Child has warm toes, brisk capillary refill, ST segments are at baseline and stable. How many people are comfortable with this blood pressure? How many people think that the brain is adequately perfused with this blood pressure? How many people feel an urge to raise the blood pressure? Can I just see a show of hands of anybody that wants to raise the blood pressure of this patient? Yeah. We're in 2023. So I saw some hands go up. I see some people who don't like the blood pressure. In about 2002, I was in the Johns Hopkins ICU and had a patient with these vitals, and I started epinephrine. And I got my hand slapped by Dave Nichols for starting epinephrine on that patient, who said that as long as the toes were warm, he didn't care what the blood pressure was. I challenged him on that. And Dave Nichols later became the president of the Board of Pediatrics. You may know the name. He writes the textbook on pediatric critical care. But that was the only time in all the years I worked with Dave Nichols where he said, you may have a point. And I'm going to tell you why we have a point. Because the brain is perfused by pressure. It's not perfused by cardiac output. It doesn't matter what the flow rate on the pump is. It doesn't matter what the cardiac output of the heart is. The brain's ignorant and blind to all that. It just matters what the blood pressure is. And I'm going to show you data to prove this. For the brain, there's this autoregulation curve. And you have some optimal blood pressure where the brain is able to totally regulate its flow using pressure autoregulation. And then you have this lowest acceptable blood pressure below which flow to the brain becomes passive, and then you have this closing pressure where the flow goes to zero. When you live in the world of perfusion, especially pediatric perfusion, you are dealing with all three of these points on this curve. So you need to understand the physiology involved. Children with congenital heart disease have a 50% incidence of acquired brain injury around the time of their surgery. And those brain injuries occur here in the deep periventricular white matter. Why? A couple of reasons. One, that's watershed. Where do your nearest probes interrogate, by the way? Up here in the gray matter. They're not looking down here in the watershed. None of our sensors tell us what's happening in the watershed, especially when we're hypotensive, but overperfused. And that's where these non-watershed areas are getting all that luxury flow. But down here in the watershed, if the pressure is inadequate, you're getting an injury. And doesn't it make sense that at these low pressures that we use, we get these injuries? I think it does. I'm going to keep going because in the interest of time. Here's the rub. The management of a child with congenital heart disease is not univariate. We think one variable at a time. What blood pressure is best for the brain? Well, the problem is this is more like a Rubik's Cube. In other words, I can solve the perfusion of the brain. I can give the right blood pressure for the brain. But on the backside of that, I may completely injure the kidneys in the process. And here's why. Because how did we go from 50% survival in 1995 to 90% survival in 2023 for the Norwood operation, or shunted patients in general, and neonatal surgery in general, by the way? How did we do that? One of the many advancements are responsible, but one of the major punctuated advancements in the survival of these patients was our understanding of the need for aggressive afterload reduction to get these children through. So when we apply adequate afterload reduction to these patients, their stroke volume increases, and that makes sense. They have less shunting from their right to left shunts, the left to right shunts that they have. They have one ventricle which pumps blood into their neo-aorta after the Norwood operation, and then all of their pulmonary blood flow is from a shunt out of the neo-aorta, stealing blood from the systemic circulation. And if their SVR goes up, they steal too much blood and they don't perfuse their systemic circulation. They get acidotic, they get kidney failure, and they die. And when we started using phenoxybenzamine in our bypass pumps for these patients, suddenly we hit an 80% survival in that era. And that was when we learned how important it was to keep the SVR regulated in these patients. And how do we know that the SVR is regulated in these patients? Is when their systolic blood pressure is low. So keeping their systolic blood pressure low was, in fact, one of the major advancements that led to the survival of these patients. So if I'm going to propose that we need to raise their blood pressure to perfuse their brain, you can see where the problem is. I may end up with a patient whose brain is well perfused and yet they're dead because they get kidney failure and acidosis in the postoperative period and don't survive. The brain, however, doesn't perfuse because of the cardiac output. And here's the data I promised for that. I'm going to show you two things. This is data from Columbia University. These are baboons on bypass. And you can see that there's a baseline measurement of blood flow to the brain. And then there's full flow bypass, low flow bypass at normal blood pressure and low blood pressure. 4 different experimental states. And you can see that when their blood pressure was normal, whether their flow was high or low or normal or whatever, they had the same flow as at baseline. But when they were hypotensive, even at high flow or low flow, it doesn't matter. They get low flow to the brain because the brain is going to take whatever flow there is as long as the pressure is adequate. Here's another reverse look at that. Kathy and I did this experiment. We put a white Lycox probe in the white matter of the brain, and we have a flow probe on the cortex of the brain. The piglet here is on bypass, full flow bypass the entire experiment, and we just added vasodilators until the blood pressure fell all the way down. And you can see there's the autoregulation curve of flow in the brain. And at these blood pressures, flow is autoregulated, and here's the lower limit of autoregulation, and the blood flow falls, whoops, if the blood pressure gets any lower than that. And that's at actually more than full flow. We were doing high flow bypass on these piglets. So full flow, high flow, whatever, that does not protect the brain from inadequate blood flow. And it requires pressure under any state of cardiac output or bypass flow. And here is the white matter oxygen tension, and you can see that it falls as well as soon as the blood pressure is low. So all these low oxygen and low flow measurements are done at full flow on bypass. So the brain requires pressure, but the kidney requires cardiac output. And at lower systolic blood pressures, your stroke volume is bigger if you're off bypass. So separating from bypass is one of the reasons why these neonates need a very low blood pressure to keep their cardiac output going. So here's another look at the same question. Here, Kathy and I put a flow probe on the kidney, and we have a flow probe on the brain. Now we're going to lower the animal's cardiac output over the course of about 4 hours by a gradual exsanguination, which results in lower and lower and lower and lower cardiac outputs over that 4-hour window of time. Initially, you start here, 100% blood flow to the brain and at a normal blood pressure for a piglet at 60 millimeters of mercury. And here's the kidney, 100% flow at normal blood pressure. And what happens as the cardiac output starts to fall? Well, initially, the blood pressure doesn't change at all. So the brain just keeps making these same points here over and over, but in the kidney, the blood flow to the kidney starts to fall all the way down to 10% of its baseline value before the blood pressure has even started to fall. So the cardiac output is lowered, and the blood flow to the kidney has been lowered to 10% of its baseline value, and the blood pressure hasn't even changed yet. So the brain's totally ignorant of all this. It's still got full flow, but the kidney's at 10% flow. So that's your patient with heart failure and normal blood pressure, because they're angiotensin 2 and norepinephrine release and vasopressin release, and their splanchnic beds are all constricted, and all of the blood flow that they have is going up to their brain. It's taking it all. Then those mechanisms fail. The cardiac output falls further. Now the blood pressure begins to fall, and the brain still takes all of the flow. And the kidney is just exhausted of blood flow at this point. It's not getting any until you hit the lower limit of autoregulation. Once the blood pressure is at the lower limit, then the blood flow to the brain starts to fall. But the kidney is long since toasted by then. So how would you get blood flow back to this kidney? I hear people say, raise the perfusion pressure. No, absolutely not. Do the opposite. You give a dilator to that patient with heart failure. You give milrinone. You give whatever it is that you're going to do to dilate that patient. And then those kidney vessels are going to dilate. The blood pressure will fall, but the blood flow to the kidney will go up. Now, your urine output may fall because your filtration pressure may be down, but your nutritive flow to the kidney will be preserved, and you're more likely to have a survived kidney at the end of that. You can do that safely as long as your blood pressure doesn't go below the lower limit of autoregulation. Let's say that again. You can vasodilate safely as long as your blood pressure doesn't go below the lower limit of autoregulation for the brain, because at that point, the brain's going to lose control of its flow, and you're going to have a reduction of flow in the brain. So what is the lower limit of autoregulation for the brain? Do you know that number for your patient? You don't. Do you know that number for a 5-day-old baby? You do not. That is a major knowledge gap. So Kathy and I, and I'm going to move faster through this, Kathy and I set out to make a monitor that would tell us what the lower limit of autoregulation is. How do we, answering this question, how do I achieve lower afterload, but not go below this dangerous number? How do I get effective control of afterload without compromising perfusion of the brain? We could talk about measuring blood flow. And a lot of people were doing that in the 1990s with transcranial Dopplers, with different techniques to measure blood flow. The problem is the blood flow to the brain is different from minute to minute and in different regions of the brain. And the scatter plots of flow measurements you get make it difficult to say, well, this is what the blood flow should be, so target this. In other words, in this region of the brain, the blood flow may be really lower, and in this place really higher. And should you try to force the brain to have a certain blood flow? It's a much better strategy. And people have written about this more eloquently than I can. People have written this, that it's much better to put the brain in a position to control its own flow than to try to force the brain to accept some value of flow. That's why measuring blood flow in the brain has failed. That's why it hasn't illuminated anything for us. What we need to do is figure out how the brain is regulating its flow and measure that. And then we can say, now the brain's in charge of its flow. Now we have optimized conditions for the brain. And this is my mentor in the research that Kathy and I did. It's Marek Shasnica. He's a physicist in the neurosurgical unit at Cambridge University. And he published this paper, which really got me started on all this work. I was at the time taking care of a lot of head trauma patients in the ICU, and you can imagine children with head trauma. This is a very important question. What is their lower limit of autoregulation? How do I manage their blood pressure and their ICP to keep their brain perfused? He published this paper, which demonstrated a technique to measure autoregulation and use that to find optimal blood pressure. And I said, wow, what a breakthrough. And I went to Cambridge and I looked at what they were doing and I got their software and I brought it back. And then Kathy and I killed a whole lot of pigs figuring out how to make this stuff work and get this to work for kids. So I'm going to show you that. This is a piglet experiment that Kathy and I did. How do you measure autoregulation? How do you monitor autoregulation? Well, autoregulation is a simple concept. The brain is trying to keep the flow constant and the blood pressure keeps moving around. So if the blood pressure is moving, the brain has to be constricting and dilating to oppose the blood pressure changes and keep the flow constant. In other words, the brain has to modulate resistance with the changing pressure so that the flow stays constant. And without getting too much into it turns out that this is also a frequency-specific event. So fast blood pressure changes pass through without being autoregulated, but slow blood pressure changes get autoregulated. And so part of what we had to do is figure out which waves we need to use to analyze. And there are these waves in all mammals in the blood pressure called slow waves. And they last between 30 seconds and 5 minutes. And all mammals have them and they're vasocycling events. And they modulate in their frequency and amplitude based on the clinical scenarios. But we don't really talk about them much because nobody really knows what to do with them. Well, it turns out you can use them to measure autoregulation and monitor autoregulation. So here's a piglet. These are slow waves in the piglet's blood pressure. And this is A is the normal blood pressure piglet. C is the same piglet with low blood pressure, below the lower limit of autoregulation. Now I'm showing you the intracranial pressure, and this was intracranial pressure was what the neurosurgical unit at Cambridge was using. We can't use that. You can't drill a hole in somebody's skull and put them on bypass. That is a bad idea. So one of the things Kathy and I did was we worked on a way to use infrared to measure blood volume and recreate the ICP waveform. And that's what you see below the ICP there is an infrared-based blood volume measurement. And then there's the flow, and you can see that across these changes in blood pressure, the flow is constant in the piglet's brain. But below the lower limit of autoregulation, you can see these slow waves are happening, and you can see now that the ICP is bouncing up and down, and the blood volume is bouncing up and down. But look there are waves in the ICP and the blood volume here, and there are waves in the ICP and blood volume here. What is the difference between them? It's really simple. If your blood pressure goes up, what has to happen to keep flow constant to the vessels? They have to constrict, and that drops the blood volume, and that drops the ICP. And if the blood pressure goes down, the blood vessels have to dilate, and that raises the blood volume and raises the ICP. So what's happening is in a state of autoregulation, these things are going opposite each other. So what you see is if you take the blood pressure and turn it upside down, it fits into the ICP and it fits into the blood volume. And it creates a negative correlation relationship or a phase shift, if you want to use that terminology. When you're not autoregulating and your blood pressure goes up, the vessels do nothing. So they get pushed open. So now your blood volume increases and your ICP goes up. And then when the blood pressure goes down, they passively collapse, blood volume goes down and the ICP goes down. So now instead of going opposite, they go with each other and you end up with this tight positive correlation. And you can measure that by continuously correlating the blood pressure with the ICP or the blood pressure with the blood volume. And I'll show you some of what that looks like. When you continuously correlate the blood pressure and the blood volume or ICP, you get this correlation score, which is between 1 and -1. And when you plot those correlation scores as a function of perfusion pressure, everybody makes these U-shaped curves. The U-shaped curve in engineering is an optimization curve. And what you can see is there's a range where these scores are negative. And remember, negative correlation means intact autoregulation. And then there's this range down here with positive correlation, which means lost autoregulation. And so what you're looking at is this child fell off the back of a motorcycle, had a head trauma, And this is that child's autoregulation curve. And this tells you that you should keep this child's blood pressure here and not here. Wow, that's pretty revealing. No longer guessing. We did a lot of experiments where we created a gold standard in a piglet where we made these autoregulation curves. And then we looked at different ways to measure autoregulation and did receiver operator characteristics of all the different techniques. And the only reason I bring this up now is because we demonstrated 2 different methods that work very, very well with high receiver operator characteristics. And we showed a lot of methods that don't work. That even though there's a p-value that they're testing something, the actual receiver operator characteristics were very poor. And I tell you this because there's a lot of stuff coming on the market and they're using these things that don't work, that have been in the literature that we showed, don't actually measure autoregulation. So be careful and ask yourself, has this been shown against a gold standard to actually measure autoregulation? All right, in order to make this safe for bypass, I told you we had to do this with infrared, and this is the ICP-based measurement of autoregulation, and this is the infrared-based measurement of autoregulation. These are 10 piglets. The lower limit, they're all normalized to their individual lower limit, and you can see that below the lower limit, the values are high, and above, they're low, giving us very good receiver operator characteristics, which means basically against a gold standard, these methods work, even the infrared method. Here's that same piglet on bypass. There is the infrared-based measurement of autoregulation showing you that this is where his brain was autoregulating. This is where it's not. This is obtained with nothing but a near sticker and an A-line. These are invasive probes in the brain measuring autoregulation invasively, and you can see that it's giving the same result. All right, let's talk about an adult study of this. Big randomized trial, took 10 years to finish, published in JAMA Surgery. When we did this randomized trial, we measured autoregulation and we told the perfusionist where to keep the blood pressure, or we did not show them, but we measured it anyway. And I'm going to show you, I'll show you the results, but the first thing you have to ask is this safe to do? In other words, if I told you, you have to keep this patient's blood pressure at 70, is that safe? What are you going to have to do that? Are you going to have to give more phenylephrine? Are you going to have to give higher flows? Are you going to harm the patient in some other way? So this is our interim safety analysis of that study. There's 140 patients in the control, 140 in the autoregulation group. And you can see there were fewer patients on dialysis, fewer patients with kidney injury, fewer patients with sepsis, fewer patients with prolonged mechanical ventilation, less multi-organ failure, less inotrope use on day 2, and less death, all statistically significant. And that was just an interim safety analysis. So my conclusion from this was, it is safe to monitor autoregulation and keep a patient's blood pressure above their lower limit of autoregulation. These were adult patients having CABGs and simple valve surgeries. In that same population, I could ask, is it feasible? In other words, if you knew what the lower limit was, can you keep the patient's blood pressure above that lower limit? Can you learn it in time to make a difference? And if you do know what it is there anything you can do to keep it? That's feasibility. So what we did was we looked at the 2 groups, the standard and the autoregulation targeted group, and then we looked at the area under curve of duration and magnitude of blood pressure below the lower limit. So how often and how low did they go below their lower limit? And if the perfusionist knew the lower limit of autoregulation, they spent half as much time below the lower limit of autoregulation. In addition to that, what's fascinating to me is that the mean blood pressures between the 2 groups were not significantly different. Wow, 71 versus 74 millimeters of mercury between the 2 groups on average during their bypass run. So I conclude from that it is feasible to monitor autoregulation and keep a patient's blood pressure above their lower limit of autoregulation. We've shown that it's safe and we've shown that it's feasible. The last thing that you want to show is efficacy. Does it make a difference for the patient outcome? Well, when we looked at MRI, published in this cohort of patients, the truth is no, because all of the brain injuries on all of these patients were embolic. So they had the same rates of embolic injury, whether you manage their blood pressure above the lower limit or not. And that kind of makes sense. But when we looked at postoperative delirium, we got a very different result. There was a 30% reduction in the incidence of postoperative delirium in the patients who got managed with their blood pressure above the lower limit of autoregulation. And that does make sense because that's not necessarily embolic. Those are people having watershed injuries from low blood pressure in their brain. So in adults, we've shown that it's safe, that it's feasible, and it's efficacious. So are we ready to do this on kids with the Norwood? Absolutely not. No way. This is not ready. Why? Because of everything I said about afterload reduction. Just because I've shown that it's safe in adults doesn't mean that it's safe to do in a newborn having cardiac surgery. And adults were surviving cardiac surgery in 1995 when everybody was dying from, every neonate was, struggling to survive coming off bypass. It's a very different game. And potentially raising the afterload or putting a limit on afterload reduction, which is the key to getting them to survive, is a very dangerous proposition for these patients. And so we are repeating these studies in newborns, and we are now enrolling patients in a multi-center trial, newborns having cardiac surgery, to have their lower limit visible to the team or not, in the same way we did with adults. And we're going to do the same feasibility, safety, and efficacy all over again in this population before we start saying, hey, we should go there. But I would say, if you're taking care of adults, this data is pretty strong. It's about as strong as we have data for any of the monitoring devices we use. If you think about it, we don't have data like that showing a difference in any outcome for years that have been randomly applied. We don't have data like that for a pulse oximeter. We don't have data like that for any of the monitors that we use. I feel like when these things come out and they're imminently coming to the market, if there's a reliable monitor that has been shown to measure autoregulation in adults, I would feel very comfortable trying it and seeing how comfortable I am using it based on the data that we've done. So thank you very much, and I'll be happy to take any questions.